looks like Dr. Solis, Kim has briefed you. Thought it made more sense to do something more academic, a bit more rigorous today, and then have a bit more fun with my last lecture on the 5th. And also, I understand you are all excited about Future Day. So that last lecture is kind of taking what we've learned about projection and exponential thinking across multiple fields, medicine, space, exploration, policy, technology, AI, and projecting 100 years in the future. So I've done that talk and updated it over the years, and it changes every time. My predictions from 2015 have turned out to be wildly inaccurate in some respects and scarily accurate in others. So I do update that lecture. What I would like to hear from you all as I prepare that talk is send me your thoughts on what you wonder about, what keeps you up awake at night, or what your shower thoughts are about the future, what you would like to see incorporated in that talk. You all come from very interesting backgrounds. So I'd be curious to see, how I can build my talk and tailor it based on your interests. So that's my plug for March 5th. And then I understand there's a class dinner afterwards, so I'll do my best to join you.
Yeah.
So, without further ado, we'll get on to today's lecture. So this is kind of my jam. This is what I love. This is space medicine, exploration. So it's pretty dense. There is probably more material than we could ever cover in an hour and a bit. So what I'll do is take questions as we go along. I'm happy to spend more time on other sections than others. Here are our learning objectives for today. So basically, I want to introduce you to space medicine, what the spaceflight environment is, challenges in physiology, what we do to keep humans alive in space, and what space medicine, mitigation, operational space medicine is all about. How that translates to challenges in the future, what we're still finding out, what our big hurdles are. And then what the ramifications for us are, how we can get involved if any one of you are interested, and what our next, holy grails are in space medicine, and then finally how they translate to benefits in technology spin-offs, what those are here on Earth. So, starting off with spaceflight physiology, we're going to start with a little bit of a thought experiment. So, what happens when you go to the vacuum of space? I really love this infographic. So, imagine that you have a jetpack, and that's all you had, and you wanted to go to space, and you didn't think about the ramifications of going high up into space. What do you think would happen? You didn't have a helmet or anything. Yes, exactly. So you're ascending on your jetpack. This is the Rocketeer, I think. He's going up 100 kilometers above the Kármán line where space is arbitrarily said to start. You get into space. First thing you notice is that space is really, really, really cold. The second thing, so the background temperature of space is about 3 degrees Kelvin, so just above absolute zero. The next thing you notice is there's a little bit of a pressure differential. So who here's ever been hiking at altitude? What do you notice if you bring a pop can with you?
Expands, right?
It expands, but it also makes a bit of a mess. So imagine that you're having a tug of war with someone, you're trying to keep that door pushed closed, and the other person is trying to push it open. When you have a greater pressure differential, and say suddenly the pressure when you're at altitude decreases, there's suddenly, if you're going back to the door analogy and one force is weaker, suddenly that door is going to go wide open. So coming back to the pop bottle analogy, you open your pop because of the greater pressure differential, soda expands and there's a great big mess. So what does that mean for our bodily fluids? Bad news. So once you get into space, will your head explode? No, but the death will be quick and painful. So your bodily fluids will freeze. Certain of your tissues are more expansile than others and will have the capacity to stretch, but others will straight up rupture from the great pressure differential. So your lungs, your sinuses, you're kind of out of luck in those departments. Your tongue might just expand, your blood vessels will start to expand, but they'll also simultaneously freeze. Your eyeballs won't rupture, but they will also simultaneously freeze and expand, causing irreversible blindness if you can get back into safety quick enough. Bottom line is, it's not pleasant.
Wouldn't you be done in before you got to space on your jet?
Yes, so that's a good point. So there's also the lack of oxygen, which presents a bit of a problem. So even when you're flying at altitude, if you're above a certain, so when you're flying in a commercial jet, if you're flying transatlantic, you're at about 39,000 feet. The reason that you can sustain that without additional oxygen is because the air cabin is pressurized to approximately 8,000 feet. So you have enough oxygen. So even if you're flying at altitude, you need to pressurize the craft. I've flown in unpressurized research crafts at 19,000 feet, but it also means we're breathing pure oxygen at that point. And what you notice, so we did science campaigns out of high-level Alberta when the mosquitoes are awful in the summer and you're just covered in mosquitoes, but the nice thing is as soon as you go to altitude, the mosquitoes drop. So yes, hypothetically, if you were still alive before all of that happened, that's what you could expect. So the other scenario is imagining a suicidal astronaut who goes to space or has a breach of their spacesuit and suddenly they're exposed to the vacuum of space. Bottom line is, nothing good happens without protection. So what I'm trying to get at is space is trying to kill you. And that's just the hostile environment itself. So when we talk about the spaceflight environment and how our physiology changes, the effects are multi-pronged. So there is the radiation and the multifactorial effects. So over a long term, so radiation is dose dependent, radiation type dependent, and exposure dependent. So you can have acute radiation sickness, but you can also have long duration spaceflight effects depending on which tissue is exposed. So based on your knowledge of radiation, what are some effects you might expect to see?
You burn from it, right?
Radiation burns in an acute exposure. The one that a lot of us think about when we think about disasters like Fukushima, 3 Mile Island, is long-term cancers. When we look at the duration on something for a round trip to Mars, which would be 6 to 9 months one way with current technologies, it's the equivalent of a full body CT scan every 5 to 6 days. And there are some that hypothesize that the cataract, your lenses will opacify from the radiation, giving you cataracts. And by some studies, approximately 25% of your crew would be blind by the time they got to Mars. That's from the radiation alone, and just from the radiation exposure that occurs once you get outside the protective confines of the Van Allen belts and the magnetosphere that protects the Earth. Then you're exposed to solar particle events, SPEs, as well as background galactic cosmic radiation, which is that ionizing, high energy, penetrating radiation. So bottom line is, radiation, not good, need protection. And in fact, there have been close calls. So one of the real threats that we worry about when we get to space is having adequate radiation protection, looking at the sun's activity, looking at what we can predict from what we know of solar weather in terms of solar flares, solar cycles. And it was in one of the, I believe it was one of the Gemini missions in the 70s that the astronauts landed 3 days before a solar particle event with enough radiation that would have killed the crew. So that's just radiation. What else is unique about the space environment? Why do so many people want to be astronauts?
Weightlessness.
Weightlessness. So weightlessness is fun. There's many ways to simulate weightlessness, but when you're used to something, you kind of take it for granted. And 1G is no different. Here, growing up on every single species that has evolved on planet Earth has, whether you're talking about dinosaurs or blue whales or humans, have had the luxury of growing up and evolving in a 1G environment. So when you take away that environment, what happens next? the bottom line is everything is affected, whether you're talking about your bone mass, your bone density, your muscle mass, your fluid shifts, your neurovestibular systems, your neuroocular systems. Your body suddenly doesn't know what's what. So there's short-term effects. So there's something that we call the space adaptation syndrome, which affects approximately 2/3 of astronauts, males more preferentially than females. And in the first 24 to 72 hours, your brain doesn't know left from right. You know, you'll see a hand floating there and you'll say, whose hand is waving? And then you'll realize it's your own because your arms just tend to float upwards in gravity. Your neurovestibular system, so how we coordinate balance is a fine act between what we see, our proprioceptors, the nerves that tell us where we are in space, and how our brain processes all this information, as well as our inner ear and our vestibular system. So to kind of give you an idea of how coordinated that act is, I want you all to close your eyes, and then I want you, once you close your eyes, to bring your 2 index fingers to meet right in front of your nose. So go ahead and try it. Close your eyes. Who here missed? The first time I tried this, I missed because my brain was suddenly unused to thinking where it knew where it was in space versus lacking that visual input. So a lot of these systems that we take for granted on Earth are suddenly need to readapt in space. And so the consequence with the space adaptation syndrome is that you're nauseous, you're throwing up, you're a bit foggy, you have headaches. It's just not a fun time. Luckily, this syndrome is known to pass maximum by 4 to 7 days, is responsive to medications like Gravol, promethazine, scopolamine, and is one of the safety mitigation factors that is built into an astronaut's operational space work schedule. So no critical procedures like spacewalks are scheduled within the first 3 days of an astronaut arriving on station. And to kind of hammer home how critical that is, imagine if you got to the space station, you were sick as a dog, and then you were sent out on an EVA to do a spacewalk, and suddenly you threw up in your suit in 0G. First of all, gross. Second of all, an asphyxiation risk. So that's how spaceflight physiology impacts operational work schedules on the ISS. To kind of go into microgravity in greater depth, when we talk about how circulation is affected by the 1G environment, I mean, for those of us who stand on our feet, we need to look no further than our swollen feet at the end of the day, varicose veins, because blood tends to pool where gravity, where the pressure differential is highest. When you get into space, you get a fluid shift, and your fluids shift upwards, and what you can see that manifests in several ways. So first of all, your baroreceptors, your chemoreceptors are interpreting this as having more fluid load, so you're peeing more. You feel congested all the time. If you look at pictures of astronauts pre and post flight, they develop what's called a moon face because of the fluid shift is causing all this congestion. In terms of taste, it translates into always having a cold when you're on station. So the nutrition and the food that's served on ISS is reflected to be more flavorful, more spicy, so to get over that congestion. It also translates into what we call the neuroocular syndrome, or the space adaptation neuroocular syndrome, called SANS, relatively new phenomenon, in which we're finding that as part of this fluid shift, astronauts, they're a hardy breed, they never ever wanted to be taken off mission, we're scared to say, hey, I've noticed my vision has changed permanently after flight. And this was a relatively new phenomenon, kind of since 2012, that became a subject of research at NASA's Johnson Space Center, which focuses on the medical aspects of human spaceflight. And these astronauts were finding that, the researchers were finding that as a consequence of this fluid shift, the cerebrospinal fluid that bathes your spine and your brain is shifting upwards, causing headaches, causing a crossover into the neuro-ophthalmic system. So that vision was affected as well, that the optic nerve that sits at the back of your eyeball and leads into your brain showed some signs of disc flattening, as well as ultrasounds of the eyeball on station demonstrated flattening of the globe. So, you know, this is after decades of spaceflight. We've been sending humans up into space since the late 50s, and only in 2012 did this become a recognized phenomenon to mitigate. So that's also part of how spaceflight affects, or the microgravity environment affects human physiology. There's been notes of immunosuppression, spaceflight anemia, where your red blood cell load is decreased by 20%, a time-dependent effect of being in zero gravity, where the more time you spend in space, the more bone density you lose, as well as needing to keep up your muscle mass. And so we're going to talk a little bit about how this is mitigated in the next slides. In addition, there's the environment itself. There's the psychology of being confined in a tin can with your crew for hurtling through space for months at a time. There's your altered circadian rhythms, your altered day-night cycles. So when you're on the International Space Station in low Earth orbit, you're experiencing a sunrise up to 16 times a day every 90 minutes, which for those of you who are very sensitive to light can imagine how that might disrupt your functionality, your performance, your cognition. There's the need to maintain a safe atmosphere, have very tight atmospheric controls, and closed loop life support systems. Look at things that you wouldn't even think about here on Earth, off-gassing of organic compounds, scrubbing the atmosphere of that, trying to figure out how to have redundancy in that system to make sure that if your system fails, like the toilets you might often hear on the ISS that get backed up, how you might fix that, have a backup plan, or have a second system. And then there's the everyday life stuff. Vibration, noise, trauma, abrasions, burns, electrocution. So all of these things. So here's a summary slide, and what we're also noticing is that there are gender-dependent effects. So, for example, the space adaptation neuroocular syndrome seems to preferentially affect males. The space adaptation sickness seems to preferentially affect males. There's the radiation-dependent effects and how that preferentially affects male versus female gonads. Women have to deal with the fact that they will go through their menstrual cycles in space. How do they mitigate that? Most of them choose to be on birth control to mitigate that extra inconvenience. And then from one of the flight surgeons at JSC NASA, what I was also told is that the toilet on the ISS responds to some fluids well, but tends to get clogged up with blood. So there's all these practical considerations when it comes to the human body, how we take it for granted every day in 1G, and how we adapt ourselves for space. So what is space medicine then? Space medicine is the realization of the spaceflight environment and putting that into the context of human factors, of the mission parameters, of the technical parameters of your mission, and putting all of these things, mission, environment, craft, vehicle, person, crew, and looking at how you can maximize human performance, mission objectives, while minimizing clinical effects. And so how do we do that? It starts with prevention and monitoring. So when we look at medicine, there's all sorts of fields. There's, preventative fields, public health, epidemiology, occupational health. There's slightly downstream, there's family medicine, there's high acuity, there's trauma surgery, critical care, emergency medicine. And on the spectrum of medicine and how it fits into spaceflight, one of the most poignant things I've ever heard said about space medicine is by the time you're dealing with an emergency or a medical issue in space, you failed because your first civ is prevention. And you do that through countermeasures, selection, and monitoring. So one of the biggest things is selection. So this is the discussion we'll get a little bit later of who gets to fly, how strict is it, and what happens when you have commercial space saying so safe that anyone can fly, even your grandmother. So when you look at governmental space agencies like NASA, the European Space Agency, the Canadian Space Agency, the parameters for selection are very, very strict. You can be the best possible astronaut candidate in the world, but sometimes genetics may be your unlucky lottery ticket and why you will be screened out. And from previous Canadian selections, there's been stories of excellent candidates who've been screened out because of mango allergies, which are known to have cross-reactivity with latex allergies, previous ski injuries causing a back injury, which has screened out a candidate, asymptomatic kidney stones. The fluid shift that we talked about means that certain types of kidney stones become more prevalent in spaceflight. So even if you're walking around pain-free, that's a screen-out criteria. So you're starting with the healthiest of the healthiest. NASA astronauts go through rigorous annual checkups, as well as pre-flight checkups, as well as pre-flight quarantines. So if you watch movies like Apollo 13, any dramatic moment where you see the astronaut, holding up their hand with their family through glass, that's when they're demonstrating the quarantine aspect. So that's the pre-flight. We talked about how we know certain effects. We expect certain effects of the spaceflight environment. So we expect muscle and bone density to decrease. So if you were put in charge of NASA's space medicine program tomorrow, what would common sense tell you that you should try to do to keep your astronauts healthy in terms of bone density and muscle mass?
Space workout regimen.
Yeah, exactly. That's one key aspect. What else have we talked about this lecture? We've talked about preventing problems before they even happen. So when you look at astronauts, they're all about prehab, in-flight, in-hab, and rehab. And so the in-flight portion consists of up to 2 hours of resistive exercise and aerobic activity every day while on station. That's on top of their heavily packed or operational schedule, doing science experiments, station upkeep, spacewalks, outreach with schools and educational organizations on Earth. Famously, Sunita Williams ran the 4-hour Boston Marathon while she was up on the station. Just as famously, for those of you who follow late night TV, Stephen Colbert launched a campaign to have one of the ISS station modules named after him, and because he has such a great following, he won the NASA competition. They overruled him, but their trade-off was that they named their treadmill the Colbert. Which in space is an acronym. I don't remember what it stands for. We talked about prevention. And then the post-flight rehab. So who here's ever seen an astronaut splash down, astronauts being taken out of their landing module? What do you notice about that? Is there anything that leaps out at you?
They're carried.
They're carried, yes. And why do you think that is?
Because they lost all the muscle mass.
They've lost muscle mass and they've decompensated. So what do you think would happen if they tried to stand up and say, nope, I'm a space hero, I got this?
Fall over.
They fall right on their face. And so what I've heard about landings is that they're trained to be very disciplined, to smile, to look like they're having the time of their lives. But keep in mind, they've just been on re-entry subject to high G loads. They've had a high acceleration, deceleration mechanism, and they've also been in space for months. So they're decompensated. The valves in their veins are decompensated. So what they'll suffer from if they stand up is orthostatic hypotension. They will not have the adequate valvular flow and muscle power to perfuse their brain. So they're carried out. They still make it look good. And then what they're subjected to once they're back on Earth is rigorous post-flight screening, as well as rehab, as well as constant monitoring of their bone mass, their blood cells, their red blood cells, their hemoglobin, their bone density. So there's lots of data repositories. It's kind of this balance between realizing that you have a small population. So to date, approximately 600 people have flown in space. So and each mission is fairly small. Only 12% of those are females. So you want to get as much data as you can, but you want to heavily anonymize it as much as possible, because you still want to, these are your patients at the end of the day. One thing we haven't talked about so far, a couple things. So nutrition. So when we talk about nutrition on the ISS, and we're related to this a little bit later, is it's very expensive to send things to space. Most commonly quoted figure is, how much do you think it costs per kilo to send something to space? Any ideas? 100,000. Luckily not quite that much, 10,000 US per kilo. With the advent of new commercial space launch companies like SpaceX, like Rocket Lab, that's projected to come down. But as you can imagine, does it make sense to send up a bag of oranges up to space? No, why not? Water. They're heavy. Do they have a long shelf life? No. So when you're thinking about nutrition on the ISS, it has to be flavorful, it has to be appealing, it has to be nutritious, it has to be lightweight, it has to have a long shelf life, and it also has to be easy to prepare. They just got an easy bake oven and baked chocolate chip cookies for the first time on ISS this past year. But these are all the considerations that go into well-being of astronauts. There's mental well-being surveillance, so every astronaut will have private teleconferences with the flight surgeon, as well as dedicated time with their families per week to talk to them. And then finally, there's the actual medicine, because as much as you prevent, as much as you plan, as much as you mitigate for medical emergencies, something's going to happen. So then the decision becomes, how do you treat that? So knowing what we've discussed so far in this lecture, what would your considerations be when trying to plan for what you would need on board your medical kit? Say you're the crew medical doctor. What would you want on the ISS? Or how would you plan for it? Any ideas? So there's a couple of considerations that go into it. So keep in mind that you don't actually have a dedicated doctor every mission. If you happen to have an astronaut that's a physician, awesome, convenient, but also keep in mind they're usually no longer practicing as physicians, they're full-time astronauts. So you have a dedicated crew medical officer on each ISS mission who's received 40 hours over their 2 years of astronaut candidate training and then whatever mission workup they had for that particular mission. So it can't be, you can't assume that you have a physician capability up on the International Space Station. And so whatever you use has to be easy to train. You have to determine, so here's a question. Does it make sense to have C-section capabilities or deliver a baby on the International Space Station? Why not?
There's a pregnant person in space.
Exactly, there's no pregnant person on space. So I've put up a very tiny version of the NASA risk mitigation matrix, and you don't need to be able to read it, but basically you need to know how to approach risk. So when you look at mitigating risk, you need to determine how likely something is to happen versus how severe it is if it does happen. So for example, if someone needed an emergency C-section on the ISS, that would be very severe, but the probability is near zero that that will happen. If someone has a paper cut on the ISS, that's higher probability. Is it mission ending? No. So the two things you look at are loss of mission and loss of crew, and what the probabilities are. If you look at something like a bad headache from congestion or inability to sleep, well, that's mid to high probability and at least medium severity, because if you can't sleep, you can't perform, you can't process, and that affects the mission. So then maybe you want something in your medication kit that is a sleep aid. So these are all the trade-offs you're thinking of as you're designing your crew kit for the International Space Station. So you want to look at what mass that every element of your kit is, how much volume you have dedicated on the International Space Station. Remember, as much as you might want as a space physician, you will not get the space you want. You have to determine if there's any devices that need power, how much power it will draw from the station, what the shelf life of anything you put into your medical kit or medications are. Are they multi-use? You can have a medication that's very good at treating one condition, or you can have an antibiotic that's known to treat both skin infections, urinary tract infections, pneumonia, sinus infections. So think about things that are multi-use. And then how easy are things to use for someone with 40 hours of crew medical training? So that's kind of the overview of the operational aspect of space medicine. From the ground support team, you're looking at a international array of flight surgeons at Johnson Space Center, Kennedy Space Center in Kazakhstan, Canadian Space Agency, looking at all the partners. So the International Space Station is international. It's the 5 key partners are the European Space Agency, NASA, Roscosmos, the Russian Space Agency, Canadian Space Agency, and JAXA, the Japanese Space Agency. So you have support. There's also international agreements, goodwill agreements in place where, for example, if an astronaut is stranded upon landing, there's an international understanding that regardless of the political sphere, as a gesture of goodwill, countries have signed on that they will rescue, help, and return the astronauts. And then we kind of touched on this. It's a little bit, space medicine is obviously aerospace and space medicine. It's a little bit of occupational medicine, a lot of psychology, pharmacy. We talked a little bit about having multi-use antibiotics and medication, but also what is their shelf life? How often do they need to be replaced? How did they respond to microgravity and radiation? Looking ahead at future technologies, can we 3D print medications and medical capabilities on the ISS? And of course, human factors. You can design the perfect system so that humans will come and find a way to screw it up. So I really, really like this list. So once upon a time back in the day, I think I told you in my first lecture that I was an intern at Johnson Space Center. So I did an aerospace medical elective, and there's something called XMC, or the NASA Johnson Space Center Exploration Medical Capability. And basically, they have a list of top 100 medical conditions based on research, based on probability that are likely to occur and that are likely to cause loss of crew, loss of mission. And so when I was at JSC, I looked at, they have something called the IMM, or Integrated Medical Model. They look at different conditions, they look at the mission parameter in terms of size, duration, distance, and determine with statistical modeling how likely that particular medical condition is to happen and how it what its likelihood for loss of crew and loss of mission is. So I looked at these in the context, I look at specific medical conditions in the context of a long duration mission, far, far away, 9 months to an asteroid, and looked at, based on the models, if a foreign body in the eye were to happen, how would we deal with it, what would the procedure be, and what would we need in our medical kit to deal with that. So coming a little bit back to the XMC list, so this is everything that NASA flight surgeons and the researchers at Johnson Space Center have determined are things that we need to know how to mitigate in spaceflight if we're proposing to send people to Mars. So you can see basic common sense things like trauma, burns, electrocution. You can, on the next slide, we'll talk about dental, tooth infections, back pain, cardiac arrest. So there's a whole spectrum there from, not big a deal to very big deal. Here's the rest of the list. You can see things like choking, obstructed airway, dental abscess. So it's kind of it's a fun list, but it's a little bit of a scary list to look at. And then there's the things, of course, that are very specific to the spaceflight environment. We talked about acute radiation syndrome, decompression sickness, headache from CO2 scrubbers failing. So that is a very, very, very truncated crash course in space medicine, space environment, spaceflight physiology. So I want to spend the last part of the lecture talking about the challenges in space medicine, starting with the near game, talking about the near game, the far game, and the here game. So let's talk about some of the fun stuff. Talking about the moon, Mars, and beyond. So is anyone here kind of a big space fan, space nerd who follows space news? Just me, a couple of us. So you may have seen in the headlines that the big news, so last year was the 50th anniversary of the Apollo moon landing, and that was when NASA also announced the Artemis program, the plan to have the first woman put boots on the moon by 2024. So there is a big push internationally to go back to the moon, starting with the Lunar Gateway, so Lunar Orbiter Space Station. Canada intends to play a very big part of that, both in terms of building the Canadarm3, so another robotic arm for the moon, taking lead in operational space medicine. There's the Artemis program to land a woman on the moon, and then the European Space Agency has announced plans for a moon village. And basically what the undercurrent is that we're not just going back to the moon, but we're going forward to the moon. We're going there to stay, and we're using that as a platform to test new technologies and protocols. And then also use that as a test bed to further destinations like Mars, like the asteroids, like Titan and Enceladus, the moons of Jupiter and Saturn, where we have these frozen ice worlds that seem to be really good candidates for where we might find life in the solar system. So there's also the commercial space sector in which, for example, in 2016, Elon Musk at one of the world's biggest space conferences announced that he was starting the next big space race to go back to Mars. He's continued to say that he does want to go to Mars, and has made plans to at least solve the rocketry, the technical, the engineering aspects of sending people to Mars to stay, and also taking a very different approach. So as we've talked about, NASA, as you may believe, is very risk averse. Elon Musk seems to embrace risk and basically said, if you go to Mars, be prepared to die. So there's that. It may be a one-way mission for some. Also in 2016, Boeing said it would beat SpaceX to Mars, so kind of trying to spur on the new space race. But as much as there's issues with keeping people healthy in space 400 kilometers above the Earth, you can imagine how these problems may get compounded even further, even as close as the moon, and of course when we go further to Mars. So what are how does space medicine change, just off the top of your heads, if we're thinking of going to the moon or Mars? What are some considerations?
Breathing,
Breathing.
gravity.
Gravity, yes. Anything else?
Construction?
Construction. Instruction or construction?
Construction.
Construction, yes, okay, perfect. Yes, we're all on the same page. So evacuation times and from the medical aspect. So you could have maybe a 24-hour delay with evacuation from the space station, 3-day delay, 3-day transport to go from the moon to Earth, and 6 to 9 months from Mars to the Earth. So as your ability to evacuate decreases, your need to be medically independent increases. So we need to think about how we're training our medical capabilities and our medical crew. We need to think about how the capabilities they have change, how the training they have stays up to date, and how we can make them more independent. And we'll talk a little bit about that. Gravity. So actually I have a few dedicated slides on that. Okay. So with gravity, one of the best ways I've heard this phrased, one of the former chief medical officers at Johnson Space Center pretty much said, what is the gravity prescription for human health? Because right now we have data on two environments. We have 1G here on Earth, and we have 0G on the International Space Station, which It officially is a microgravity environment. There's no such thing as true zero G, but for all intents and purposes, you're weightless. So we have the two ends of the spectrum. But what about when you go to 1/6 gravity, where you're 17% of your Earth weight on the moon? What about when you go to 1/3 gravity on Mars? What aspect of that? So which of those minimal gravity environments is enough to maintain bone health and cardiovascular health and prevent that fluid shift? Is it 17%? That's great news if that's the case, because then we can be much more confident about how we're going to perform on Mars. Because if you think about it, we talked about how the astronauts are decompensated when they come back to Earth after being in zero G. Now imagine that you need at least 50 to 75% of Earth's gravity to maintain your bone function and your ability to perfuse your brain. Now imagine you're sending astronauts on a 6 to 9 month journey in zero G to Mars. And now imagine you're telling them that as soon as they get to the ground on Mars, that they have to be functional and start building a permanent operational base. You need to mitigate for that. How, if we plan that they're fully decompensated, do we increase the amount of dedicated resistive exercise they have to do every single day for those 9 months in flight? Do we build them exoskeletons that can help them perform and build while they're out on Mars? So that's the gravity prescription, is how much do you need for what duration and at what exposures to maintain human health? And we'll also talk about this a little bit more in as we get to the sexuality reproduction aspect of future challenges in space medicine. So the next two aspects we'll get to in a sec. So the other thing I want to say about looking at far away destinations is our training has to change. So right now we have crew medical officers. I think there are very few people who would argue that you don't need a physician if you go to Mars. You need a doctor, you need that clinical ability, but you also need a Swiss Army knife of a doctor. You need them to be able to do the preventative stuff, the family doctor, general medicine stuff, but you also need them to be able to deal with acute hemorrhages, broken bones, possibly even performing a trauma laparotomy in case of an internal bleeding. And you also need them to be able to maintain their skill sets. If you ever talk to a physician, most of us will tell you that if we've been away from work for a couple of weeks, it takes us a few days to get back into the rhythm. We feel rusty as we pick up our skill sets again. So how do we maintain our skill sets on Mars while not detracting from the mission? What tools and technologies can help us? How can AI and diagnostic algorithms help a single clinician make better clinical decisions? How can just-in-time AR and VR guidance and training? So I mentioned the company I work with, Lexonic, in my first lecture, and how we're working on both VR medical imaging to help physicians consult in real time across distances, and also how we're working on 360 VR for medical modules, both for space and for remote locations on Earth, to help maintain those skill sets. And so these are some of the considerations. The bottom line is, though, the further away you go, the more independent you need to make your medical capabilities. So I'm just going to switch over to the psychological resilience aspect of training. So I think this is from, this is either Interstellar or, I think this is from Interstellar, or The Martian, one of the two. It may not be. Okay. So when you talk about psychological resilience, who here's ever seen the movie The New Right Stuff or heard of it? So it's a classic. It was based on a book, but it's about what it takes to be an astronaut. And so what are some of the qualities you would think an astronaut should have?
Discipline.
Discipline?
Small.
Yeah, that's actually a great point. Low resource utilization, very practical point. Okay, would you want someone who's brilliant but has a personality of House MD on your crew? Well, why not?
To maintain proper group order.
Yes, to maintain cohesive group dynamics. The bottom line is no one wants to be voted off the habitat. You don't want to be the one who wants to sleep outside on Mars. It wouldn't end well. So one of my areas of research, so I've written 2 book chapters, and the first one has to do with psychosocial resilience in long duration spaceflight. So there's rigorous, along with the medical screening that we talked about, there's also rigorous psychological screening that goes on for selection of astronaut candidates. And so basically you want someone who's very, very good at what they do, has the capacity to learn across multiple domains, but is above all, first and foremost, a team player. It can't just be me. But this is the data that we have for low Earth orbit in the International Space Station. So how do we need to tweak these psychological parameters as we talk about going further? What is the balance between introvert and extrovert? There's some data that shows that the most highly performing groups are groups that are a little bit more introverted than they are extroverted, but have high group cohesion, because that means they all work well together, but they're not all about socializing, they're more focused on mission objectives. So the resilience aspect of how you choose your astronauts, how you choose your crews, how long you train them together before they actually go on this multi-year mission, may be tweaked a little bit as we talk about longer duration missions. And so some of the, here's the one from, here's one of my favorite scenes from the Martian fiddle play. Maybe not. So I liked those 2 particular scenes in Interstellar and The Martian. Who here's seen Interstellar? So do you remember when Matthew McConaughey's character first gets to this stranded astronaut on this foreign planet, and this long stranded astronaut tries to kill him? So it's the rule number 1 of astronaut school: don't try to kill your teammates. So it was a great example of what you don't do. On the flip side, I really like this clip from The Martian because it's an excellent character study of exactly the traits you would want in a crew member to survive on Mars. He's resourceful, he has a sense of humor, he always makes short-term plans for what he needs to do today while looking along to the long-term plan. He makes plans for growing potatoes. He creates a plan for what he's going to do to the potatoes that day. He makes plans for developing a communication system and then tests that out, going a little bit further every day, and finally makes plans to reestablish communications with Earth. So he has an expeditionary mentality, and he also has that survival mentality. And there's actually research around psychology, psychological resilience, and coping. And the research basically shows that resilience isn't an innate trait, but can actually be built. And the reason I like talking about this is because I think it has a lot of application for our daily lives in academia and medicine, just in daily life. And so the research around resilience says that this can be broken down into the traits of breaking things down, taking things step by step, having a positive social support circle, positive self-talk, so telling yourself that you've got this, impulse control, resisting the urge to give up, and then mentally rehearsing for both the best and worst case scenarios. And similarly, there's research around coping that sounds a lot like the research around resilience, and this is actually taken from looking at crews in austere environments. And so one thing I haven't talked about yet is how we find out about the best crews and data, and we look at what we call analog environments. So analog just means an environment that has certain characteristics that are similar enough to space that they would give us data points that would help us for space. So we look at military deployments, we look at oil workers on rigs, we look at crews in Antarctica. There's analog space habitats all across the world. I just finished a 2-week tour at the Mars Desert Research Station in the Utah desert, where we call it real life fun fake Mars, because we're essentially living in a tin can as a crew. If we go outside, we have to suit up in our space suits, because otherwise the environment would kill us. And so there's actually data taken from studies of crews in these isolated and confined environments, also known as ice environments. And the research around coping, similar to the research around resilience, says that coping comes down to planful problem solving. So again, there's that breaking things down, relying on those social supports, being able to endure harsh conditions. So I think that's another way of framing impulse control. Emphasizing the positive, so there's that positive self-talk, and also relying on luck. And I think another way to frame that is gratitude. So that's kind of one of the future considerations as we're talking about more complicated, longer duration, further off missions. So the other area of research I've written a book chapter on is sexuality and reproduction in space. So off the top of your head, is this problematic or not? Is it a consideration?
For sure.
For sure, yeah. So, I mean, if we're purported to go to the moon, not just to visit, but to stay, if we're talking about creating not just stations on Mars, but permanent settlements, that implies a permanent human presence. And when we talk about colonizing Mars, it's a bit of an archaic term, but we're also talking about having a generational presence. And so there's a joke in the space industry that says, the dinosaurs didn't have a space program, look where they are now. And so there's kind of this survival mentality that says, okay, if we want to be, if we want to increase our chances of survival, we have all our humans in one basket now, so we need to be a multi-planet faring species. But the thing is, if you need to be a multi-planet faring species, you need to know how you can successfully reproduce in that environment. And so the bottom line is a lot can go wrong with sexuality and reproduction in space. So we're going to talk a little bit about that. So this is my slide saying we're going to talk about the space birds and the space bees. Here's a philosophical question for you. If you give birth in space, is it an illegal alien? All right, so there's also a lot of ethics around this. So just to jump ahead in the interests of time, when we talk about reproduction, it is a multi-step process. So you need to have healthy gametes, you need to be able to successfully copulate, you need to have a sperm and an egg that meet, form a zygote, properly implant, develop, go through all of gestation, initiate labor, have a successful birth, and then finally focus on the postnatal developmental period. So that's the overview of of development. So now imagine doing that in a zero-G environment. Things can go a lot wrong at every step of the way. And we have data on animal studies. So we have data from zebrafish, mice, rats, jellyfish, wasps, even human gametes that basically are very conflicting, and the bottom line is more data is needed. So for example, coming back to this idea of a gravity prescription, when we look at neonatal rats who have been flown in space but not necessarily born in space, there is a neuromotor, there's a disability with their musculo and motor development that disappears by 3 months. When you look at wasp offspring that have been flown to space, at wasp eggs that have been flown to space, and then returned to Earth where the eggs have hatched, there's a higher rate of death in that wasp population. Why? Nobody knows. In zebrafish, there's higher rates of optic lens opacification. So there's all these things that could potentially go wrong, but there's also data that says that conflicting data. So when we look at libido in male astronauts, some have postulated that because of the zero-G, there may be problems with even initiating a proper erection, whereas in one of the astronauts' biographies, I can't recall which one, he writes in very, very vivid detail that he had one of the best morning erections of his life. And so the bottom line is, we need to start thinking about all of these things if we're proposing to seriously be an off-world, multi-world faring species. And we need to be looking at the data in animals, in mammals, and we need more data, and we need to look at every aspect of the gravity prescription. You know, how much gravity do we need? For what duration? At what exposure? Does it need to, you know, can a sperm or an egg float in 0G if exposed to a 1/3 gravity environment? Is it still viable? What are the effects of radiation on that environment? So imagine, hypothetically, we managed to overcome all of those barriers. We've solved, you know, the problem of gestation development in microgravity and 1/3 gravity. There was a company that, for obvious reasons, just as quickly as it appeared in the past 4 years, proposed to, I think it was called Project Human to Cradle, fly a pregnant woman to space and have her give birth in space after inducing labor. What are some issues with that?
It's dangerous to both the
Risks.
mom and baby.
Absolutely. So, risks, yes, lots of risks.
Have
So,
any mammals been born in space?
I believe with the rat studies, the rats have been born in space, and I think that was the neuromotor effect that disappeared. But I would need to double check because it may have just been a brief exposure in utero, and then they were born. So I'll check and get back to you for the next class. So with pregnancy on Earth, so many things can go wrong. A baby can be breech, not head down. A labor can arrest, either due to failure to fully dilate, failure for the baby to descend. There could be issues with bleeding. There can be issues with a cord prolapse. Basically, pregnancy is 90% super exciting, 10% sheer terror from the medical aspect. So now imagine you're dealing with all of these in a partial gravity environment. Now remember the discussion we had at the beginning of this lecture, where you are severely constrained by mass, by volume, by power. So now you're proposing, if you're planning to have obstetrical capabilities on Mars, now you're planning to expand your medical repertoire to include operational capabilities. You're going to have to commit yourself to either creating medical devices that are multi-use or, you know, dedicate the mass of needing, you know, C-section forceps, a vacuum, things that are single use that will eat into your mass budget. So there's so many considerations with the whole idea of reproduction, delivery in space. And of course there's the postnatal development. And I know this has been explored in science fiction. You know, if you have a child who's born and grows up in 1/6 gravity, in 1/3 gravity, how is that going to permanently alter their physiology? And is it going to be detrimental or deleterious enough that they are forever confined to the moon or to Mars? Are they ever able to travel to Earth? Or will their bones decompensate? Or will they be unable to bear the weight of 1G? And of course, the ethical and logistical considerations. So, right now, NASA is viewed as very family friendly, and so they don't really talk about this type of thing. So, what about if there is no policy around this, and you have so then how does this dictate what your crew to Mars will be? Do you just say you're going to have a single gender crew, when you know the data out there says that mixed gender crews perform better? Are you going to say that you can have a mixed gender crew, but everyone has to have either tubal ligations or vasectomies? Or are you just going to say that astronauts are a cut above, they won't do that, and it'll all be fine? Or, you know, what about the ethics of fraternization, even if you're not worried about the logistics of reproduction? Say this is a government-funded mission, and it turns out 2 of the astronauts have begun a relationship. And on top of that, they both have spouses on Earth. Because this is taxpayer funded, is there a duty to disclose? What if, because of cultural beliefs, you know, there is a single same gender relationship that starts and that causes cultural friction on the habitat? How is that dealt with? And so, you know, it's fine to say that, you know, that's far ahead in the future. But the bottom line is, coming back to your Mars habitat, to be prepared for space, you need to be consider all and every single scenario and come up with contingency plans for all of them. So this is kind of a summary of all of the ethical issues we just discussed. So, in the last part of this lecture, I want to talk about how we go about building medical capabilities. We've already talked about the challenges of deciding how you triage what you need. So this is kind of when I brainstorm, when I think about building a permanent presence of medical capabilities on the moon, I like to think of it, building it in a stepwise fashion. So right now we talked about having that basic in-situ training, the crew medical officer with 40 hours of training. So that can be the first building block, but then building in stepwise fashion as if you imagine we have successive operational resupply missions to the moon, building on those capabilities one by one, much as you would build up a medical clinic in the desert or on a military deployment. Increasing your medical capabilities to have advanced life support, and then increasing your field capabilities with protocols for when things go wrong on EVAs, increasing your medical capability when you're doing a moonwalk and an exploration, and kind of building it up like a field hospital, and then slowly increasing your longevity to look at preventative measures, screening, and primary care capabilities, and all the bells and whistles, all the extras, like having the capability for obstetrical capabilities, for colonoscopies, if you're having a permanent presence on the moon. But before that needs to come your life-saving, so your life-saving capabilities, your emergency OR, your emergency surgical capabilities. Okay, so switching tracks in the last few minutes here, talking about the near game. So we talked a little bit about this, about commercial spaceflight. There's companies like SpaceX, Blue Origin, Virgin Galactic. Virgin Galactic says, so safe your grandmother could fly. They're talking about flying suborbital vehicles up in flights that last minutes to hours, up above the Kármán line. So you can say you've been in space, you get 4 minutes of 0G. So how does our medical screening change? Because when you look at the spectrum of air travel and aviation, we've talked about the rigorous screening and why that's in place for the International Space Station. At the other end of the spectrum, we have commercial air travel, which there's very little screening. Flight attendants, if they see someone acutely sick, do have the right to prevent someone from boarding. And there's been recent news stories about families that have, there's been someone with the flu, someone's been inebriated, they haven't been allowed to fly. So that's kind of their screening process. There's international guidelines for the medical as well as first aid kit capabilities, as well as the training of a crew on a commercial airliner. So where in that spectrum does this technically going to space but not being there for a long time, does that fall when it comes to screening medical backgrounds for passengers? And so there's actually a lot of talk about this. There's data around it. There's been centrifuge studies where they've exposed subjects between the ages of 19 to 89 with every thing from a heart transplant, congenital heart defects, type 1 insulin, type 1 diabetics on insulin pumps, who've actually all done very well when subjected to the G profiles, the 6G front to back profile, the 4G up and down profile. And they've all done really well, and it turns out the number one reason why someone's screened out from those studies is actually doing something unsafe, anxiety, or claustrophobia. And what they're finding from the personality inventories that they performed pre-centrifuge study is that it doesn't actually predict who's going to end up not being able to fly on the centrifuge because of personality, because of psychological anxiety or claustrophobic issues. So this is kind of just one of the reviews on the subject that I've done with my life sciences team with the Association of Spaceflight Professionals. And basically, the bottom line is it's a very interesting topic. There's some good medical data out there, but there's also a lot of questions and liability issues and ethics that remain to be answered because these companies are charging 6 figures for a flight but if you're medically screened out, what is the process? You know, what is the balance between safety and running a business? So I'm happy to chat about this later because it'd fill hours. So then we're just going to spend the last 2 minutes talking about the here game. So next challenges we've talked about, so I'll skim through those. And then I'll just end with resources and benefits for Earth. So we talked about everything that can go wrong in space. Here are the academic references to the space adaptation neuroocular syndrome. This is a great article in the New England Journal of Medicine about civilians in the era of modern space flights and space medicine. And then this is a relatively new finding that's come out in the last year where on this line of space can kill you, doing routine ultrasound studies of the internal jugular vein, one of the astronauts on the most recent mission was shown to have a clot. They had to anticoagulate the astronaut, and this raises all sorts of questions for long duration spaceflight. Are we now in a hypercoagulable state where we're now prone to venous thromboembolisms that can potentially cause us harm or kill us? So coming back to getting involved now, so I've mentioned to you in my background that my other life is being a scientist astronaut candidate and doing a lot of citizen scientist astronautics. And so some of the work we do is flying 0G, so parabolic flight. So that's when you take an airplane and go up and down, accelerating upwards at 2G, leveling out, giving yourself 30 seconds of 0G, so you're weightless, so you can conduct limited science. Because you're falling at the same rate of the plane and then pulling out at 2G. So here's how kind of we've contributed to medicine and how we're contributing to medicine. So we've also tested, the initial reason that we were doing the parabolic flight was to increase the space readiness of the spacesuit that you see that I'm wearing. We've also tested it in water crash landing scenarios, and then where the space medicine comes in is I'm actually the chief instructor for the operational space medicine course through this organization, where we look at protocols in an austere, resource-limited environment, knowing everything that we've talked about. We teach the basics of assessment and triage, and then we look at when you throw in the space, a space flight environment and scenario, how does your assessment need to change? What challenges will you run into, and then how does your tools need to change? So I talked about the Mars Desert Research Station and what we can learn from analog environments. This is a picture from the Utah desert. Oh wait, so in the last negative minutes, sorry about that you guys. So I just this is actually a good place to leave off, because we've talked a lot about design and how we think about design. And what drives design. So when we talk about spin-off technologies, we talk about spin-off and spin-in, and we talk about technologies from space that have benefited Earth, and we also talk about technologies on Earth that have benefited space. And when we look at commonalities, we talk about these ice environments that are resource limited, that are remote, that need increased medical independence. And so when we look at drivers, we've already talked about what drives technology for space. It needs to be lightweight, it needs to be hardy, it needs to be low power use, it needs to be radiation resistant, it needs to be portable. And so you can imagine how something that all those things will have equal use in the Arctic, in a remote community in Inuvik, or in Antarctica. And so these are actually excellent drivers for technology innovation. And so basically your bottom line is you want something that's functional, increases survival, and safety. And so these are all examples of space medicine technologies that have been spun off to have benefit on Earth. So here you see an ISS water filtration device where the resins have been used to purify water that's being employed in villages in Kenya, portable ultrasound being used for obstetrics in a village in Inuvik, air scrubbers from the atmospheric scrubbers on the International Space Station that have been used in transport, in the produce transport chain to increase the longevity and shelf life of the produce. Solar powered refrigerator to keep vaccines nice and cold despite being in an environment with no electricity. So these are all examples of how space has benefited Earth. And so the bottom line is you need to look at when you're looking at drivers of how you design, what is the probability that you'll need to use it? How does it mitigate your risk? Is it simple to use? And how does it fit into your paradigm of mass volume power constraints? And so there are opportunities to both benefit Earth in everyday medicine, in the developing world, and also spin-offs for space. So that is kind of where I'll leave it. For those of you who may be interested in space, in austere environments, I included a whole schwackload of links to conferences, to Project Possum, to Canadian chapters like Students for the Exploration and Development of Space, the Canadian Space Society, the Association of Spaceflight Professionals, and also more austere environment stuff, so wilderness and diet medicine. So those will all be there for you at the end of this lecture. So that was a whirlwind welcome to the world of space medicine. There you go. Any questions? Yes?
Is rotational gravity, like if you're the same as Earth gravity? If you're, if you've got one of those spinning machines
Yeah.
to create gravity in space?
So what you're talking about is, for example, in Space Odyssey 2001, where they have the rotating space station and they create 1/3 gravity. So yes, that is technically, in theory, doable. It's just super duper complex and expensive, which is why no one has done it yet. But for example, in the Martian movie, what you noticed is that to mitigate this whole decompensation issue is that their space station had that rotational artificial gravity. So it is technically a thing, and it would technically be beneficial. It's just that it's very hard to do.
So we don't know if the body responds to it identically as it would.
No, because then you come down to the question of so the proposals I've heard have simulated 1/3 or proposed to create a 1/3 gravity environment. So then the other question is 1/3 gravity enough to prevent all of these deleterious effects?
What type of effect does being in space for a prolonged period have on the heart?
Yeah, that's a great question. So there's actually great research that was done at the University of Calgary that showed that there was vascular stiffening based on modeling done in 0G. And then I think Bob Thirsk actually looked at rat models of that on the ISS. So there's a lot of research around it out of there, and I want to say Western, so a lot of great Canadian research that shows that there's decreased wall, what's the word, tensility? So there's increased stiffness. With heart, so your heart is, when you look at cardiac output, you look at what the efficiency of your heart is. You're looking at the heart rate times the stroke volume. So because of the fluid shift versus decreased fluid, your heart is working harder. So there are known both whole heart effects as well as vascular effects as well from being in 0G. Any other questions? Well, thank you all for staying beyond time. I appreciate it. If you have any questions, email me. If you have any thoughts on how you would like to see the future being defined for the March 5th lecture, remember it's to celebrate Future Day. This is your class. Happy to build the presentation for you guys.
Great. Thank you.